So welcome to the oral abstract session. This is hopefully going to be the best session of the whole meeting. We're super excited about this session because we have a lot of new data that's going to be presented, and we're super excited about that, like thinking about the evolution of this meeting and how far it's come, all the work that Toni and Hans that have put in. So thank you all for submitting your abstracts. These are key studies with all fresh new data being presented. The way that we're going to kind of break it up is we're going to do the first two abstracts, which are the clinical trials, and then we're going to pause and do some Q&A, 10 minutes of Q&A. Hopefully nobody goes over time. And then we will do the latter half, the remaining four, which are more translationally oriented, and then we'll group the question and answer for the latter four. So with that, we'll get started.
Okay.
Yeah.
So our first presentation is going to be with Dr. Choueiri. It needs no introduction. Take a little time to get up here. And it's going to be on combination HIF-2 alpha inhibitor plus Cabozantinib in previously treated patients with clear cell renal cell carcinoma. It's an expansion cohort from the ARC-20 study.
Oh, thank you, Wesley, and thank you, Rana. I don't know if the mic is working. Is it?
It's not.
No. Is this working?
Yeah.
Hello, is this working? No. So just this one. I can do this one. This one. Okay, this one works. I think. I'm confusing you, right? Okay, this one works. Great. So let me put it here then. That's smart. Okay, so let me tell you a bit about a new story with a new HIF-2 inhibitor by the name of Casdatifan. What I will present here is not something that is new in a way, but it's a combination of some preclinical work, single agent activity, as well as combination with Cabozantinib that has been presented over 3 meetings, the ENA, the triple meeting, ASCO GU in 2025, and recently ASCO 2025. So I don't need to tell this audience that HIF-2 alpha, this transcription factor that is a key driver in the development and progression of clear cell RCC. The problem with it, unlike some of the downstream protein of HIF-2 alpha, is that it has been very difficult to target because typically, beside historically the steroid receptor, HIF-2 alpha has been very hard to tackle, but some elegant crystallographic chemistry work showed that there could be a small molecule that can get into one of the HIF-2 alpha pass B pocket and inhibit this dimerization with this obligatory partner HIF-1 beta ARNT. And that's lead to the downregulation, and that's what Casdatifan does, of multiple, I'm not going to say only protein, molecule, etc., pathway involved in oncogenesis. Angiogenesis and oxygen sensing is one through VEGF, the hypoxic response, but EPO is just as important, but also multiple other pathway, as you can see here. This is some preclinical work showing that Casdatifan suppresses serum EPO, which we used in the time of Balzutifan and now in Casdatifan as a downstream marker. These are on the left PK, PD, derived changes in the serum EPO as a function of the dose of Casdatifan. We started from low dose, and what you see here is 25 milligrams. That's about to suppress at 70%, but we can go up to 90% here with higher dosage. And the dose that I will tell you about, that's going to be the single drug dose, is the 100 milligram. Now, this is a bit of an unfair comparison when you look at Balzutifan, because these were not conducted at the same time. They're taken from different origin and fused together. Nevertheless, people have done it before. And as you can see here in red, it's Casdatifan at 100 milligrams. That's the dose that we're progressing in phase 3 trial in combination, and Bel 120 milligram approved doses. The serum EPO, both dropped EPO, but perhaps there is more. Perhaps, again, sustained decrease over time, and more so with Casdatifan over EPO. So what we've done overall is we tested the half-life here. It's around 24 hours. There are some HIF-2 inhibitors that had some challenges in being developed because their half-hour were days and days and days. There is dose and concentration dependent reduction in EPO after a single dose and multiple doses. This was consistent with HIF2 inhibition. And the optimal dose that we identified of Casdatifan is 100 milligram in combination with Cabozantinib. That's the dose we identified. I'm not saying that's the MTD based on toxicity, based on pharmacodynamic, dropping EPO, based on what we saw in terms of activity, even with small number, toxicity, etc. We ended up with 100 milligram. And I would say even when the development of Belzutifan, I know it's 120 milligram, overall, when the program moved, there was some reasoning to go higher in the dose, and that was the reason LightSpark 13 was done. Overall, from single agent in the dose escalation, there was the toxicities, wherever they are, the same. Anemia and hypoxia were manageable. So the whole program is named ARC-20. That's the phase 1 dose escalation and dose expansion study of Casdatifan as a single agent here, or in combination, or in other cohort in general, or in specific cohort that are pre-specified. Let me tell you a bit about the single agent activity, focusing on 50 milligram twice a day. That was the initial, then 50 milligram once a day, then 100 QD. You have around 30 patients in each cohort. Here, mostly intermediate risk group. In the single agent, these were heavily pretreated patients. Every patient experienced disease progression on VEGF and PD-1 inhibitor, mostly as a combination. And the 80 to 90% of patients had 2 or more lines of therapy. This is the most important slide to remember with single agent. Response rate range from 25 to 33%. Be careful also when you talk about response, especially in agent like HIF2 inhibitor, that tend, in general, not to have an explosive response like TKI or like the combination of TKI plus PD-1, where we know the median time to response is at your next scan. It takes sometimes, and we saw that experience with other HIF2 inhibitor like Belzutifan. With the 100 milligram, 33% response rate was 5 months only of median follow-up. The rate of PD was 2% here, only 1 patient has PD, and these are the waterfall plot here, as well as the spaghetti plot. I love spaghetti to call them, especially after lunch, showing that most patients, with some exception, have some sort of tumor stabilization or decrease here. The second part, I want to show you another cohort, and all the cohorts are accruing and going. Some of the cohorts are monotherapy. I know Dr. Brugarolas asked, rightly so, to develop HIF2 inhibitor in specific cohort as single agent earlier. Yes, we do have in favor risk first-line clear cell RCC. We're accruing to the Casdatifan monotherapy. And we have specifically post-IO Casdatifan monotherapy. But what we have matured is a combination to prepare for the phase 3 I'm going to show you of full dose Cabozantinib 60 milligram a day and full dose Casdatifan 100 milligram a day. We presented that at ASCO. So 42 patients. In terms of baseline characteristic, nothing surprising. Most of them are intermediate risk, and all of them had experienced progression on prior line of therapy. Less heavily pretreated than you think. 1 line of therapy, the majority of them. And actually 60% experienced progression on IO only. Those are patients that had experienced progression on Nivo-Ipi or while on adjuvant Pembrolizumab, and the rest, they had VEGF TKI plus IO. So a unique set of patients. The response rate after 5 months of follow-up, so median follow-up is 5 months, 2.8 to 9 months, is 46%, with 1 patient experiencing PD, very few CR here. So when Dave McDermott talk about cure and CR here, hopefully most of these become CR, but you know what? It's not going to happen. But 4% of patients had CR. Response rate, 46%. All of these are PR. This is the PD patient, around 27% increase. And the rest of the patient, except 1, experienced some sort of tumor shrinkage here. These are the swimmer plot. This is preliminary, time on treatment. Most of the patients remain, as you can see here in the dots, ongoing responses. Now, what about toxicity? We put them all in one slide to tell you there was no surprises for on-target toxicity. The two big things we think about with HIF2 inhibitor, anemia, hypoxia, hypoxia, anemia. So here, again, depending on the follow-up, with more follow-up, of course, patients stay on therapy more, so there is more room for a toxicity to appear or a toxicity to change from grade 2 to grade 3. You can see the most important one are anemia. Hypoxia, luckily, so far has been 10% or less. If you look at monotherapy 100, let's focus on it because that's what we're taking as monotherapy or combination, 17%. That's a bit, I have to say and admit, lower than I thought. I think the sites here were experienced with prior HIF2 inhibitor and had a lot of checks and balances in for anemia. So 17% of grade 3 or higher, and 10% of hypoxia overall. These side effects, when you talk about Cabozantinib and Casdatifan, in general were manageable with fewer than expected dose reduction, whether related to Casdatifan. The majority of dose reduction, no surprise, were related to Cabozantinib, 38%, 24% related to Casdatifan, and with the single agent, the dose reduction were all less than 10%, which is kind of refreshing. I know it's hard sometimes to tell, despite a bit the non-overlapping toxicity between Cas and Cabo. Let's face it, when you have anemia, it could be Cabo. When we have fatigue, it could be either, because fatigue happens, whether related or not. Remember, with reporting in the NCTAE version, whatever version, it's yes or no, related, not related. There is no much playing this possibly, probably, likely. It's yes or no. And most of the time, at least for me, when I don't know or when I'm not 90% or more sure that it's not related, it's related until proven otherwise. So I want to announce 2 phase 3 trials. These are present on cancer.gov website. That's why I'm putting them. And you're familiar with PEAK-1. PEAK-1 will be a study that evaluates the combination of Cas-Cabo versus Cabo plus placebo. The progression would have happened only on prior PD-1, but VEGF inhibitors will be allowed. HIF2 inhibitors will not be allowed. The primary endpoint will be PFS and 2-to-1 randomization, 2 for the experimental arm, 1 for the control. And the second study is a frontline study by the name Evolve RCC02, and this is a seamless, well, that's a wishful thinking. It's a seamless phase 1b/3 design where we start with the phase 1b. This is an attempt to have a TKI-free regimen as first line, where we're going to test 2 doses of Volru. Volru is a bispecific PD-1 CTLA-4 that showed activity already in frontline metastatic clear cell RCC with 2 doses of Volru with Casdatifan. And from the phase 1b, the wishful thinking is that we're going to go directly to phase 3. That will involve intermediate and poor risk. The phase 1b it will involve all risk, but this will be intermediate and poor risk, where we will have randomization to the combination of PD-1 CTLA-4 HIF2, PD-1 CTLA-4 versus standard of care Nivo/Ipi, with PFS and OS being the co-primary endpoint. Now the randomization is 1-1, followed by 1-1-1, followed by 1-1. What do I mean? That means it's over 1,000 patient study. Once we reach 200 patients here in Volru for the combination for the single agent activity and the contribution of the component, then we will cap here and continue randomizing to the combo versus Nivo/Ipi. And that's it. Off to Dr. Albiges, and then we can take Q&A.
Thank you for that, Toni. Toni did the pleasure of introducing Laurence. Welcome, Laurence. Thank you for joining us to give an update on the B61 study.
Thank you, Rana. I really want to thank the KCRS for the opportunity to present on behalf of all my co-authors the update of Pembrolizumab plus Lenvatinib for patients not previously treated with advanced non-clear cell RCC. That's the keynote B61 study we have been discussing throughout the meeting. So these are my disclosures. And as of a background, everyone is now familiar with the fact that Len-Pem is one of our standard of care, both for clear cell RCC, but also on the ground of B61 for non-clear cell RCC. And so B61 is the largest study that has been conducted assessing Len-Pem in non-clear cell in patients that had metastatic or advanced disease. And what is important here is it's a not randomized study, so it's a single-arm study. We initially reported the study when we had 15 months follow-up. Then more recently, Martin Voss here in the room reported the almost 23 months follow-up. And what I'm presenting here today for the first time is the update of the study with a minimum of 3 years follow-up. So these are new data. So this is the design of the study. Patients with non-clear cell entity were receiving as frontline treatment Len-Pem in the regular way you've been using it in clear cell. The primary endpoint is response rate assessed by blinded independent central review. So overall, over 200 patients were screened. Ultimately, 158 were treated. With the follow-up we have now, many patients had discontinued, and then the first reason would be disease progression. But interestingly, we still have some patients that are ongoing. And the median follow-up we have with this follow-up is, with this update, is about 42 months. And I want to pause here because this is the first time we're having a study with this kind of follow-up in non-clear cell. You're used to see that for clear cell RCC, but it's great news for our patients that we are now having data of prospective study with long-term follow-up. So this is the study patient population. As I mentioned, 158 patients. This would be mostly papillary patients, 93 of them, chromophobe, 29 of them, unclassified, 20 patients, translocation, and then some small numbers of medullary and others. So these are the main findings of this update. With this over 42 months median follow-up, we have a response rate that is right above 50%, consistent with the prior reports. What is increasing actually is the complete response rate. We were in the 8%, now we're reaching to 10%. So yes, we can achieve complete response in some of our patients. And so to the right part of the slide, you can see the response based on the histopathology. So as I said, over 50.6 for the overall patient population, 53.8, almost 54 for papillary RCC, 31% for chromophobe, 66.7 for the translocation, and so on. So with long follow-up, we confirm the high response rate that is actually even increasing if you think of papillary, for instance. And this is the waterfall depicting the change from baseline by each histology. So in a patient that is responding, how long is it going to last? This is the duration of response. So we're looking only at responders. The median duration of response is now reached and is increasing over time with more follow-up, almost getting to 2 years. I think this is extremely important. Earlier in the morning, we mentioned ESPN. So ESPN is actually one of the manuscripts Toni made me work on when I arrived here in Boston about 12 years ago. And so I pull out the numbers of ESPN. So ESPN was, you may recall, Sunitinib versus everolimus. And the PFS at that time was 6 months. The overall survival was 16 months in the overall patient population in the trial. The response rate was 10% with Sunitinib. So we've been from 10% now to more than 50%, and we're having this great response, durable response in some of our patients. The progression-free survival in this study is almost getting to 18 months. This is stable with a prior report. And to the right is the PFS by the two main subtypes, papillary and chromophobe. This is overall survival. Median overall survival is 41.5. Of course, this is overall, as I say, the median follow-up we have. But this is the first time we're presenting this data, we're excited to see how we've been evolving the field with combination therapy. Although not randomized, I think to me this has been a game changer in the way I handle my patients. And so what about subsequent therapy? Because some of our patients will require further treatment. As you will see, in this study, we had 61 patients who received any subsequent therapy, mostly driven by a VEGF TKI, but some of patients could receive mTOR or even PD-1 inhibitor subsequently. Now, with regard to safety, this regimen is one that we've been using now for many years. We are very comfortable with using it. It does mean sometimes reducing, especially the Lenvatinib component of the combination, but there's no new safety signal when compared to when we're treating patients with clear cell RCC. The side effect is mostly driven by the high blood pressure, the diarrhea, and some of the thyroid toxicity, with the specificity, as you know, with proteinuria with this agent. So in conclusion, after a minimum follow-up of 3 years, and I stress the median of 42 months, Pembrolizumab plus Lenvatinib continue to show a durable anti-tumor activity and promising survival in the first-line setting for patients with non-clear cell. Response rate is above 50%. Our patients that achieve complete response or partial response are having long duration of response. Median PFS is now in the 18 months, and ultimately, the PFS rate and the long-term OS rate are extremely interesting, depicting the long-term benefit our patients are deriving. So as of now, this is one of our standard of care to treat patients including papillary or chromophore, so different histologies, the non-clear cell. And we're excited that this has changed the paradigm for our patient. And I really want to pause here to thank the MSD team and Rodolfo here, who supported the idea of having a study in non-clear cell. Thank you very much.
Thank you so much, Dr. Albiges. So we have a few minutes for questions now, about 5 or so. Anyone from the floor? I can go around and help with this. I think in the back already.
Laurence, great talk and obviously very provocative data. You mentioned, if I recall the number correctly, 10% of patients had sarcomatoid. I suppose that's across different histologies. Do you know what the response was in that group?
Yeah, so I don't have that top of my head, but this is definitely something we've been looking at. And the other thing, one strength I did not mention, is that we had central review in this trial. So we were very happy to see that there was a strong consistency between the local read and the central review. And of course, we are eager to see if the sarcomatoid component could help us to have a strategy, but once again, we're not randomized, so that will speak to the fact that we had a Pembro backbone in this trial.
Yes, Mike Atkins. Great presentation, great follow-up. Do you have any data on whether patients were able to stop the Lenvatinib and continue to respond, and anything about what happened after the Pembro was stopped at 2 years?
Yeah, great question. Thank you, Mike. So, how does a patient for which we discontinued treatment would perform? So as of the trial, we would discontinue Pembro at 2 years. We are just starting to look into that because now we have the follow-up to answer that. Some of our patients, and I have on top of my head a patient with translocation who actually is still with Len, continuous and doing great in CR. We, of course, with the long-term exposure, had to dose reduce in most of our patients. We don't yet have the data to answer the question of how would a patient perform when we discontinue either the Pembro or the TKI. But these data are being collected, so ultimately we'll be happy to add that in the manuscript.
Laurence, it was really a study, and it's so encouraging to see the results, improve like that. I was curious about the unclassified category. You had 20 patients that were unclassified, and none of them had a complete response. So maybe you could argue they weren't papillary or something else. But did you have any molecular data on those 20 to suggest that? You answered and said that there was a central review, but maybe that would have put them in a different category if you got some molecular or copy number changes to see what they really were, because that was a decent number called unclassified.
Yeah, thank you very much. My initial guess was that unclassified would be better classified by the central review. And I mean, only few of them were able to be reclassified. So some, I would say the vast majority were real unclassified. Now your question is, what about biology? Martin and I are actively pushing to have more translational piece around the trial. This is something that is a work in progress. So I hope we'll be able to answer that.
So, hey Toni, so all of us who follow the HERV2, HIF2 story and the antigenicity that's probably driven by HERV2 have a little concern about combining HIF2 inhibitors with immune checkpoint inhibitors. You have a phase 1b run-in and evolve. Is there kind of like a stopping point if you don't see a certain level of activity that would make you concerned that you would interfere with the immunotherapy component?
Yeah, absolutely. So with the phase 1b, there will be, concerns for stopping rules for toxicity, but also for activity. Definitely, when you combine two, mechanism of action that could, in theory, have synergistic or antagonistic, you have to make sure you protect the patient. We saw that in the past with combining, let's say, sunitinib and bevacizumab. I don't know if Bob is here. That was one of the supposed to be the most attractive combination. It was active, very active. It was very toxic. It caused TTPs and HUS. So everything was, put in place. We have single agent. Actually, Darren Feldman is here. I believe he was the first author many years ago of that paper, if my memory is still okay. We have single agent safety of each, a study that Laurence and Martin and Brian ran with the bispecific and with the Cas single agent. So the hope is that they'll be safe and not antagonistic. That's very important.
Any other questions?
Toni, question to you about the HIF2 alpha from Arcus. Are you surprised, or at least I'm surprised, that we don't have a higher degree or higher rate of anemia when you showed, the suppression of serum EPO? What is your explanation for that?
Yeah, so luckily I think you can make comments that you are almost sure about when it's not a phase 3 trial that involve, 50 nations. But this is, 15 sites, and I would call in usually every week for that teleconference. I think there was an aggressive management from our sites and the sites in general, and from Arcus clinical team, who was very involved in managing the anemia as fast as possible. And I think we learned a lot from the Cabozantinib experience. And all these sites that we have used Cabozantinib in the past, to start by first and foremost having a workup for any iron deficiency anemia or at baseline, etc. You would be surprised, every 7-8 patients we would detect one. So we would treat B12 folate, and then immediately after the patient reached, give them transfusion and EPO. So there was a lot in parallel things ongoing like this. On the other hand, what is interesting is the hypoxia. If the hypoxia was rate, there is no management of hypoxia except putting marathon runners on trial. The hypoxia rate, I think, is similar. So that makes me at least a bit comfortable, or at least from the number of patients, 7-10% is as similar as it can get to a highly selected Cabozantinib cohort of patients that have good baseline pulse ox.
Okay. Thank you all. So we're going to move on to the second half with our translational discussions. Our first speaker is Berke Simsak from Brigham and Women's Hospital.
Good afternoon, and thank you very much for the opportunity to present our work on tumor-associated macrophages and their effect on clinical outcomes to first-line nivolumab therapy. I have no disclosures. As it has been studied in various models and cancer types, we now know that tumor-associated macrophages promote immune suppression in tumor microenvironment. And although TAMs have been associated with resistance to immune checkpoint inhibitor therapy in several cancer types, for example, colorectal carcinoma or pancreatic ductal adenocarcinoma, their association with response has also been reported, for instance, in Hodgkin's lymphoma. For KCRCC, though, their role as predictors of clinical outcomes still remains somewhat unclear. Also, there is evidence from preclinical models that TAMs actually cause exhaustion in cytotoxic T cells in tumor microenvironment. Chemokines released from activated T cells cause recruitment of monocytes from blood circulation into TME, and those monocytes develop into differentiated macrophages. Later on, ineffective antigen presentation as well as immunosuppressive ligand receptor interactions between TAMs and TILs, coupled with secretion of immunosuppressive cytokines into the TME, cause exhaustion of cytotoxic T cells and diminish their ability to mount an effective response against the tumor. With that knowledge and background, we wanted to assess the association of CD163 positive TAMs with clinical outcomes to first-line nivo therapy in metastatic KCRCC, and we wanted to investigate whether TAMs and exhausted CD8 positive TILs reside and interact within a spatially defined niche. And with these aims in mind, we analyzed pretreatment tumor samples from 67 patients enrolled in HCRN GU 16-60 clinical trial of first-line nivolumab in metastatic KCRCC. And to identify TAMs and CD8 positive TILs in various stages of exhaustion, we utilized the workflow previously developed in our lab based on multiplex immunofluorescent staining. In the tissue, we identified CD163 positive TAMs, non-terminally exhausted CD8 positive TILs as cells defined with co-expression of CD8 and PD1, but negative for TIM3 and LAG3, and terminally exhausted CD8 positive TILs, cells defined with co-expression of CD8, PD1, and at least one of either TIM3 or LAG3. For the statistical part, association of density of CD163 positive TAMs with PFS and ORR were assessed, and we conducted a specific type of spatial proximity analysis, mostly using the SF package in R. Our results showed that density of CD163 positive TAMs as a continuous variable was positively associated with ORR and PFS in first-line nivolumab therapy, and similar results were actually shown when the data was adjusted according to the IMDC risk groups. To further explore the value of CD163 positive TAM density as a possible biomarker of response to PD-1 blockade, we developed an optimized cutoff based on minimal p-value for association with ORR to create a binary variable. And this cutoff was actually also the median cutoff for this biomarker. And patients with higher levels of CD163 positive TIM density had higher ORR of 65% compared to the patients with low level of this biomarker, which had an objective response rate of 15%. Similarly, patients with high levels of TAMs had a longer PFS, median being 16.6 months, compared to the patients with low level of this biomarker with a median PFS of 5.5 months. We then performed a proximity analysis to investigate spatial distribution of CD8 positive TILs in different states of exhaustion relative to the TAMs. On the image here, you see a representative visualization from our analysis in which the green diamonds are the TAMs, triangles are the terminally exhausted, and the squares are the non-terminally exhausted CD8 positive TILs. We determined the densities of terminally and non-terminally exhausted TILs within a 30 micrometer radius area centered around TAMs, which we called as the proximal area, and outside this area, which we called as the non-proximal area. And for both exhausted TIL subsets, we calculated their enrichment levels in proximal versus non-proximal area, and later we compared their enrichment levels with each other. When we compared the densities of TILs in proximal and non-proximal areas of TAMs, we observed that density of non-terminal exhausted CD8 positive TILs were higher in areas proximal to the TAMs compared to their densities in areas not proximal to TAMs. And actually here, the similar results were also observed for the terminally exhausted subset as well. So both terminally exhausted TIL subsets were enriched in proximity of the CD163 positive teams. But we wanted to see, but when we compared their enrichment levels, we observed that enrichment levels for terminally exhausted CD8 positive TILs in proximity of the CD163 positive TAMs were significantly higher compared to the enrichment levels of non-terminally exhausted CD8 positive TILs. And in conclusion, high levels of CD163 positive TIMs are associated with improved outcomes to anti-PD-1 therapy in metastatic CCRCC in our data. Exhausted CD8 positive TILs, especially the terminally exhausted ones, preferentially localized in proximity of CD163 positive TAMs in CCRCC tissues, supporting that TAMs promote tumor growth by inducing T-cell dysfunction. And taking these 2 points together, our data raise the possibility that efficacy of PD-1 blockade may be in part by reprogramming TAMs from a pro-tumorigenic to an anti-tumorigenic state, which could, which might be like the result of either directly blockading the PD-1 receptors on TAMs or indirectly reshaping the inflammatory niche by changing its cell population and molecular composition. I want to express my gratitude towards my mentor, Sabina Signoretti, and all my colleagues in Signoretti Lab, also all our collaborators, including the ACR and GU16260 clinical investigators who made those valuable samples and clinical data available to us. And I want to thank the DoD for supporting my fellowship.
Thank you so much. So we're going to move straight into our next translational talk by Dr. Mashlani, postdoc research fellow at Dana-Farber.
Thank you for the introduction, and thank you to KCRS for allowing me to present on behalf of my co-authors our integrative molecular and clinical characterization of circulating KIM-1 in metastatic renal cell carcinoma. So as a brief background, kidney injury molecule 1, or KIM-1, is a transmembrane glycoprotein that is overexpressed on the surface of kidney cancer cells. It has a cleavable ectodomain that allows it to be shed into the circulation where it can be detected in as little as 25 microliters of plasma. In this work, we used data from the Javelin Renal 101 trial, which was a pivotal phase 3 trial that established the combination of PD-L1 inhibitor avelumab plus VEGF receptor tyrosine kinase inhibitor Cabozantinib as a standard treatment regimen for metastatic renal cell carcinoma. So through this work, we aim to evaluate the association between the levels of plasma KIM-1, first with clinical outcomes, and second with the underlying biology in kidney cancer from the trial. So I'm sure you're all familiar with the trial schema of the trial. It randomized 886 patients with treatment-naive advanced clear cell renal cell carcinoma to either avelumab plus Cabozantinib or sunitinib. The trial did not meet its primary endpoint of OS, but median PFS was longer on the combination arm. So this is our trial design, our study design. We measured KIM-1 in plasma of 612 patients, which represent about 70% of the intention to treat population, both at baseline and 12 weeks of systemic therapy later, which corresponds to the first day of the third cycle of systemic therapy. And we associated the levels of KIM-1 with the baseline tumor whole exome sequencing, RNA sequencing, and immunohistochemistry. So these are our baseline characteristics. The cohort included 323 patients on the avelumab plus Cabozantinib arm and 289 patients on the sunitinib arm. As you can see from the table, the baseline characteristics including age, sex, ECOG performance status, and IMDC risk group, as well as the baseline KIM-1 levels, were pretty similar across the two arms. So starting with the associations with the clinical outcomes. We dichotomized our cohort at baseline using the median KIM-1 value into low and high subgroups and found that high baseline KIM-1 predicted worse overall and progression-free survival in the entire cohort. When we examined each arm separately, high baseline KIM-1 predicted overall survival on both arms as well as PFS on both arms. And it's important to note that when we did studied the interaction between the levels of KIM-1 and the treatment arm, we did not find, the interaction was not significant, suggesting that KIM-1 is rather prognostic rather than predictive biomarker in this setting. So we also did a multivariable adjustment for baseline characteristics, including age, sex, ECOG, and IMDC risk group. And baseline KIM-1 remained prognostic for both overall and progression-free survival. We also assessed whether a change in KIM-1 from baseline to 12 weeks predicted clinical outcomes. And indeed, an increase in KIM-1 from baseline to 12 weeks compared to a decrease was associated with worse overall and progression-free survival. And that was the case for both arms of the trial as well. Now, an important part of our management in kidney cancer is risk stratification. So we were interested in assessing whether KIM-1 would improve stratification for OS at 18 months. So on the left, we can see the receiver operating characteristic curves for 18-month OS. With IMDC only, it had an AUC of 0.67 or 69, while baseline KIM-1 only had an AUC of 0.67. Incorporating both IMDC with baseline KIM-1 improved the AUC significantly to 0.75. However, the best improvement in AUC was found when IMDC was combined with both baseline KIM-1 and the change in KIM-1, resulting in an AUC of 0.77. We were also interested in associating the levels of KIM-1 with the underlying biology in kidney cancer. To do that, we interrogated our tumor whole exome sequencing data to examine common somatic mutations with clinical relevance to kidney cancer. And we found that higher baseline KIM-1 levels were associated with loss of function mutations in BAP1, which is a tumor suppressor gene that is linked to more aggressive and proliferative phenotypes. And this association, interestingly, remained significant after adjustment for tumor burden. Similarly, we conducted the transcriptomic analyses to link the levels of KIM-1 with signaling pathways and immune signatures. And patients who had predominantly proliferative signatures, as compared to angiogenic ones, had significantly higher levels of KIM-1 at baseline. In conclusion, higher levels of KIM-1 at baseline and increases in KIM-1 from baseline to 12 weeks were both associated with clinical outcomes on both arms of the trial. KIM-1 is a dynamic biomarker that seems to be linked to the underlying biology and not just being a surrogate for tumor burden. And finally, we believe that prospective studies will be instrumental in order to implement KIM-1 clinically into practice and to use it as a viable biomarker for kidney cancer. I'd like to thank the patients and their families, my mentors in this project, Dr. Toni Choueiri and Dr. Vincent Chou, my colleagues at the Choueiri lab, the study sponsors who made this work possible, and finally, it was supported by the CDMRP Kidney Cancer Research Program, another one by Dr. David McDermott and the Dana-Farber Harvard Cancer Center Kidney Spore and a support grant. Thank you for your attention.
Well, our next speaker definitely does not need any introduction because she's my co-moderator, Dr. McKay, and also a Catalyst Award winner from yesterday.
Thank you. Thank you. Also super excited to present this work on lower checkpoint expression associated with primary resistance to nivolumab. Sorry, gang.
Mic drop ready.
There we go. Let's do this. There we go. There we go. Just sitting on that. There we go. Resistance to nivolumab, ipilimumab in combination for patients with advanced renal cell carcinoma. So you all know this as a way of background. Immunotherapy combinations have really revolutionized the treatment landscape for patients with advanced RCC and are now the frontline treatment standard for people who have, first-line metastatic disease. One of the biggest conundrums that we face in the clinic is who to give nivo-ipi to versus who to give IO-TKI to. We want our patients to experience that long-term durable benefit, the tail on the curve that we've seen from the long-term survival follow-up from Checkmate 214. But in reality, about 1 in 5 patients are going to have primary PD, and 1 in 5 patients are going to potentially experience that durable outcome. And there is no biomarker at the present time to actually help us better select who are those people that really should not actually get nivo-ipi, and the likelihood that they're going to have a long-term durable benefit is pretty low. So in light of this, there's an urgent need to actually identify negative selection biomarkers for treatment with nivo-ipi and a pure IO strategy in the frontline setting. So we had the hypothesis that there are molecular differences that exist among tumors with or without primary progression to nivo-ipi. So we set out on this project in collaboration with Tempus Research Labs and identified all patients who had received frontline nivo-ipi in their database. That was 106 patients who received first-line nivo-ipi. Eligible patients had to have a tissue tumor sample that was collected within 1 year of treatment initiation, and they needed to have data available from RNA and both DNA. Treatment response was investigator assessed within the first 90 days of treatment initiation, and patients were basically categorized as PD or non-PD, and that determination was made within the first 90 days. And then the RNA-seq data was normalized, log3 transformed, and it was batch corrected. And we basically measured checkpoint genes, the RNA expression of checkpoint genes, and also angiogenic gene expression. And we looked at other immunologic parameters as well, TMB, MSI status, PD-1 status, and immune infiltration. That's not all detailed here. We also did correct for multiple testing as well. So here are the baseline characteristics of the cohort. There were really no statistically significant differences that stood up with the baseline characteristics between the primary PD group and the non-PD group. There were 55 patients in the primary PD group, 51 patients in the non-PD group. You can see they were well matched, and what you would typically expect from an RCC frontline population, mostly male, mostly white patients. We did have about 15 to 20% Hispanic patients in the cohort. We included all histologies in this categorization. The main reason for that was we basically pulled the pathology reports for all these patients. They have not undergone yet central pathology review. There was a lot of patients that were categorized as RCC NOS. We didn't want to lose those patients, so that's why there's this designation that we included everybody, but we suspect that there's actually probably more clear cells than what meets the eye here. And then balance with regards to bone metastases and liver metastases. Here's a breakdown of the source of the specimens. You can see that the bulk of the specimens actually were derived from the kidney. We have some derived from tissue, and I will highlight here what's in green are the primary PD patients. What's in orange are the non-PD patients. So, throughout the slides, green is basically PD, and then orange is non-PD. It pains me to have these like Miami hurricane colors, but it kind of matches the slides. So I'm just having I'm having a little bit of trauma here, like looking at orange and blue. Okay, other soft tissue where a lot of specimens came from, bone, lung, and liver. You can see the breakout. So here's the top line data, and what we actually saw when we looked at the checkpoint RNA expression across this checkpoint genes, particularly CTLA4, TIGIT, PD-1, and PD-L1, is we actually saw dramatic differences or statistically significant differences between the PD group and the non-PD group. What's on the left is actually just the transcripts per million that are log transformed, and you can see the statistically significant differences that are flagged with the asterisk. But what I'll draw your attention to is on the graph on the right, which actually shows we dichotomized patients by Q1 versus Q4, and you can see that these are the Q1 levels for the 4 key markers that we looked at, and there's a dramatic difference with these patients having much lower levels when they have primary PD. So the likelihood of a patient having progressive disease is closer to 70%, 70%, 87%, 63%, 67% there when they have low expression of the checkpoint genes. When we looked at angiogenic gene expression markers, these are basically the markers that are present in the Emotion 151 signature. We actually saw no difference, not that we expected to see a difference, across the RNA expression of the angiogenic gene markers. And then when we looked at immune cell infiltration, there was really not a dramatic difference that was seen other than the Tregs, but this is sort of like bulk analysis. I think it's really hard to dissect this data out. We also looked at somatic gene alterations across the PD and non-PD group, and actually across the board did not find any statistically significant differences between the patients that were categorized as PD versus non-PD, even in the areas where we would traditionally think like TP53 and some other markers that have been prognostically significant. So in summary, primary resistance to nivo-ipi is characterized by lower RNA expression of immune checkpoint genes. This possibly reflects an immune cold microenvironment limited to T-cell infiltration or activation, or even immune exhausted environment. We are actually working on the validation studies with the IHC currently, and hopefully this will be presented at a future meeting to corroborate the RNA expression with the IHC. So really thank the patients and their families who had contributed to this, the collaborating institutions, Tempest, for allowing us to dissect out the data.
Thank you so much, Dr. McKay. So rounding out our abstract session is Dr. Jang, a postdoc research fellow and instructor, also Dana-Farber.
Good afternoon, everyone. It's a great honor to have the opportunity to present here on a new class of neoantigen in CCRCC that derive from endogenous retroviruses and potentially could leverage this information for designing novel targeted immunotherapy. So it's well established that CCRCC are immunogenic tumor, and typically we think tumors that respond better for immunomodulators are tumors that have higher neoantigen load, and in that sense, CCRCC kind of an outlier where it has a pretty good response despite a pretty modest mutational burden. So we argue that maybe there are some CCRCC-specific antigens that is just largely unknown are contributing to this immunogenicity. So one class of such neoantigen could be endogenous retroviruses due to some clinical studies showing that the ERV expression correlates with responsiveness to immune checkpoint inhibitors in certain cohorts of CCRCC. So just a really brief introduction on ERV where Dr. Riva described really well in the last session. So two key interesting features of this. One is it's highly abundant in the genome. It's about 8% compared to coding gene, which is only 2%. And second is that despite during evolution selection, there's a lot of mutation as well as epigenetic programs designed to silence the ERV. Some of the ERV still maintain the intact open reading frame. So when the epigenetic environment is correct, such as cancers is hypomethylated as well as demethylated on the histone side, these have the potential to be translated. So it's well known for the Richard Child's study about 20 years ago when they treat the RCC patients with allogeneic stem cell transplantation. They observed this one patient who had a complete response, and he harbors circulating T cells that recognize this ERV, that's ERV4, and is a HIF-regulated ERV. So considering how abundant the ERV is in the genome, and HIF is such a master transcription factor regulator in the CCRCC, we hypothesize there are probably additional ERVs that are behaving very similarly that should regulate by HIF and is very immunogenic. So we decided to use modern multi-omic technology with RNA-seq and polysome-seq to really systematically profile this, where we can, in CCRCC cells, engineer cells to have high HIF expression or low HIF expression to look for HIF-regulated ERVs. So besides ERV4, that's one of our positive control, we identify additional 80 ERVs that are regulated by HIF. And the next question is whether these ERV are actually divided into peptides and presented by the MHC complex. So the approach we took is that using immunopeptidomics, where we'll pull down the HLA allele on the cell surface, and using mass spec to look for any ERV-derived peptides, especially the 81 HIF-regulated ERVs. And then in both CCRC cell lines as well as in CCRCC patients, specifically we looked into the patients involved in the new VAX trial that David Brown talked about yesterday. And then in total, we identified actually 24 ERV-derived peptides. So the big question is whether any of these peptides are actually immunogenic in the RCC patients. So we thought the best setting is the new VAX trial, where we have the blood samples of these patients, and then we have done immunopeptidomics on the tumor of these patients. So we could match up and trying to see whether the immune cells from these patients recognize their own tumor antigen. And then, so we did that for 11 patients among all the peptides we identified. So we identified basically one peptide, is the KLI peptide, that are responsive, evaluated by the Alice spot. It's a little bit disappointing to us, considering how great the matchup is. And one possible explanation is that maybe these are stage 3 through stage 4 patients, their T cells are not that functioning, and then these patients have been experienced any immunotherapy yet. So we think the better reservoir of functional and maybe richer reservoir of T cells are patients who actually responded well to immunotherapy. So the first cohort patients we thought about is the patient that Dr. Richard Childs treated 20 years ago, where they have about almost 50% of patients responded to this therapy. So we reached out to him, and very luckily and unbelievably, he had all these PBMC frozen in their liquid nitrogen. So they were able to share 6 patients' PBMCs that were all responders to the allo-SCT. So we look at the PBMC from these patients that prior to allo-SCT therapy as well as post, and 3 out of the 5 that were successfully revived, we see their PBMCs are responsive to multiple ERV-derived peptides. This is just one example of a complete responder, and you could see the magnitude of response prior as well as after the therapy. Another rich cohort of patients we thought would be very interesting to look at are the patients who successfully responded to checkpoint inhibitors. So the way we do this is we teamed up with T-scan therapeutics. So we looked into the TILs of the patient who are responders to immune checkpoint inhibitors, and then identify their TCR based on sequencing, and then transduce these TCR into CD8 positive T cells, and co-culture it with 293T cancer cell lines, where we overexpress a genome-wide library of both 90 mer peptides encoding both coding genes as well as non-coding regions, which including ERVs. And then use the downstream reporter system to read out what kind of peptides these TCRs are actually recognizing. And then this is just one example where we found that ERV4 derived peptide were actually recognized by one of the VHL null patient. There are additional ERV derived peptides, and this peptide is different from the original Richard Childs peptide, but we still think that these ERV4 in completely different settings, we're able to re-identify and suggest that there are some HIF-regulated, ERV upregulated shared in different CCRCC patients. In summary, I hope we convinced you that actually we systematically identify dozens of HIF-regulated, relatively intact ERVs that had the chance to be transcribed, translated, and presented by the MHC complex, and actually are seen by the immune system, and especially the patient who had a success post-immunotherapy. And so we argue that the ERVs are probably still a good immunogenic antigen, because first of it is quite abundant in the genome. Secondly, because it's regulated by HIF, so it's probably have the possibility to be tumor specific as well as shared. And the third is because it's viral origin, it tends to be pretty immunogenic. So our initial study was very limited by just a couple cell lines as well as a couple patients, very limited HLA types. So now we're expanding this study by overexpression, all common HLA allele in the US population, and created a high HIF, low HIF status, and use immunopeptomics to really systematically look for HIF-regulated ERV-derived peptides. So this hopefully could create a good resource for cancer vaccine design for RCC patients. And at the same time, we are trying to characterize all the TCRs that are recognizing the immunogenic ERV-derived peptide, especially the shared one among patients. And hopefully these we could either have a personalized TCR-T therapy or design T-cell engagers towards off-the-shelf and shared common immunogens. With that, I would like to thank my mentor, Dr. Killen, as well as all the collaborators. So here is just a very minimum list where their work were directly presented in this presentation, but it's a great team effort, as well as my funding resource from the KCRP DoD. Thank you.
Time for questions? I'll throw as well.
A quick question for Burke. You did a really nice job quantifying the density of the CD163M2 max, and you also quantified the density on like the T cells, the terminally exhausted and antigen experienced but not terminally exhausted. But you didn't show us the data how the T cells correlate with outcome. Did you do that analysis?
You mean the correlation between their densities?
Yeah, and the outcome, PFS or OS.
Oh, so like actually our lab has been working on this in like past several years as the correlation of the clinical outcomes for like immune checkpoint inhibitor therapy for the non-terminally exhausted CD8 positive TILs, and like in several cohorts actually we saw that they are correlating with higher ORR and longer PFS.
No, but in your cohort. But in your cohort.
Oh, in this cohort, in HCRN cohort, it is actually previously presented, and yes, they are correlated with better outcomes.
And the other question is the CD163s are like the M2, the bad guys, but you're saying that they're good?
Oh, yeah, I think it is a conflicted point that like classifying the macrophages as directly M1 and M2. And on protein level, to be honest, like majority of the macrophages we see, they express CD163. So directly saying that the CD163 positives are M2s, I don't think it is very accurate. And like we have been using actually CD163 as a pan macrophage marker.
Thank you.
I have a couple of questions. So for Rana, so we heard about different efforts looking at PD-1 and PD-L1 and other checkpoint inhibitor expression or checkpoint targets and the association with resistance or sensitivity in kidney cancer. And one of the things, so we are just about accruing a 40-patient PD-L1 PET trial, and we have found tremendous variability in PD-L1 expression within primary tumors and between primary tumors and metastases. So I think one of the limitations that we are going to encounter is the heterogeneity in kidney cancer. Do you have any comments for that?
No, I think that's a very good point. I mean, this cohort was about 50% from primary, and the remaining 50% was from metastases, soft tissue, so it's not all nephrectomy specimens. So we haven't yet done the analysis teasing out, just looking at the expression levels in the Mets and grouping those. I mean, theoretically, actually, you'd probably want to do 3 groupings, right? You'd want to do the primary, the lymph node, which probably has a little bit different behavior, and then the Mets. But in other analyses, I agree with you, we've seen variability. But that's a good suggestion to actually tease this out. I do worry about the small numbers because our patient cohort's only 106 patients. So once we then take those 50 and then divide the 50 into the 2 groups of 25, like the numbers are going to get small. But even just to look at the transcripts per million that are log transformed just across the sites in the 2 groups would be informative.
Thank you. And Mark, so did you look at the association? So you found an association between BAP1 loss and KIM1 high levels, which maybe is not to be unexpected. Did you correct for Ki-67 or grade?
So that's actually a good question. We did correct for IMDC risk groups, which is not exactly grade, but we did not do Ki-67. I think we might be able to do that as well. Thank you.
Yeah, I think looking both at WHO grade and Ki-67 would be important.
Thank you.
Yeah, excellent presentations all. I guess 2 questions. I mean, first, I agree with the question in terms of CD163 sort of co-migrating with T cells. You would sort of expect that when you have an effector T cell population that will migrate in, that you're going to have a counter-regulatory macrophages that come in to basically cool it down. So that relationship you would sort of expect to see. But the question I have is for Mark with regards to the fact that you're seeing that KIM1 in the metastatic setting is prognostic, but we've seen it potentially being predictive in other settings. Comments on why is this potentially different?
Yeah, so if you remember from, I think, Dr. Shu's presentation about checkmate 214, there was a drop and they assessed KIM1 at baseline and then 3 weeks later. And in checkmate 214, the drop in KIM1 from baseline to 3 weeks was predictive on EP-Nivo, but there was no correlation with association with clinical outcomes on sunitinib. I think the timing is important. It might be due to the biology, or even maybe sunitinib or other tyrosine kinase inhibitors might be downregulating KIM1, irrespective actually of response or tumor burden. And then when we measured it 12 weeks later, it was like across the board associated with better outcomes. So I think the timing is very important. In our study, we used 12 weeks. In other studies, and there's a paper in Checkmate 009, they used 3 weeks. Checkmate 214, 3 weeks as well. So that might be explaining the difference.
We're putting Wesley to work here. I'm failing as a moderator.
All very nice talks, and thank you so much for sharing this great work. I have questions for all of you, but for the sake of time, I'll only ask Dr. Jang. You know, the background with Christoph Smith's paper from Ben Vincent's group in JCI a few years ago that a lot of us rely on for the HERV-Quant pipeline, right, is that they really associated the expression of these ERVs and RCC and other tumor types with humoral immune responses. And then George Cassiotis and Charlie Swanton had that beautiful Nature paper 2 years ago showing in G12 mutant tumors that they can actually functionally enrich for humoral immunity through ERV expression. So I'll ask the same question I asked to Dr. Drake earlier, is have you actually looked to see if there are circulating antibodies against these ERVs, and do you really think that the anti-tumor immune response is being driven by these ERV-specific TILs, or potentially more of a humoral immune response through integration of TLS and things and such?
So you're asking like whether there is possibility to design like antibodies more effective than the TILs, you think?
Not necessarily, well, sure, but are you actually eliciting a humoral immune response with these ERVs, or is it exclusively an adaptive cellular response?
Oh, you mean basically the interferon signaling signature at the beginning before the T cell?
Another really great point.
Yeah,
but,
so for kidney, I think, at least in our cell line studies, I think it's much less in the interferon signaling.
Okay.
Definitely the viral mimicry is pretty, is one part of the story for a lot of other cancers. But in kidney cancer, we haven't found that is the case. So we are thinking it's still possibly these are presented as antigen instead of just like a global derepression of all the ERVs, and then the HIF-regulated one are specifically upregulated that are good candidate in a tumor-specific way to induce T-cell responses.
Very interesting. Are you able to elicit an antibody-based response with these HIF-regulated HERVs?
So we haven't seen that, but I think in the lung cancer, they have shown evidence for ERVK with the antibody response, but we haven't looked into that yet.
Okay. Thank you.
Just another quick question for beautiful data. You know, the T-scan technology is cool. Kai Wucherfenig published this beautiful paper in head and neck cancer a couple years ago where they took TIL. They said, if you get PD-1 response, what are you responding to, right? And they found some things you expected and some unexpected. And you found ERV4, that's cool. Did you find anything else?
So we, I guess they didn't share all the data with us because we specifically asked for the ERV component, but we did see additional ERVs than just the ERV4. And then one interesting thing is that they have 10 RCC patients that responded to that, and then only the 3 patients that are VH null that they know have harbor T cells that are reactive to HIF-responsive ERV. So we do think it's a very interesting, and the other interesting thing is one of the ERV that we didn't identify as HIF responsive initially in our cell line, but through their platform we found that ERV and we checked back and it was HIF responsive in 4 out of the 10. So I think there are a lot of additional interesting ones than they are for.
Thank you.
I had a question for Rana. Rana, you looked at PD versus non-PD, but did you look into PD versus partial response?
We did not. We just grouped the whole stable disease, PR, CR into one. I think if we had larger sample size, I think that would probably be good to look at the 2 extremes and group the PRs and the CRs together and pull out the SDs. It's probably worthwhile seeing if we can do that. Additionally, I think it was a lot easier with a retrospective data set to actually tease out who's not progressing and transitioning onto another line of treatment, as opposed to the nuances between SD and PR from a retrospective data set where we're not doing like clean resist. But I think it kind of highlights that these patients that they're basically negative for their checkpoints are gonna do pretty poorly. I think as I'm sitting up here on stage, I actually think we need to look at the Venn diagram of the 4 markers that we looked at, you know, TIGIT, LAG3, PD-1, CTLA-4, and look at, like, if somebody was Q1 in all 4, what would that percent look like? And if that percent is close to like 90% likelihood of PD, because there was still 30% that could have responded, then that's something that I think could potentially be meaningful clinically, because when there's still a potential for 30% benefit rate, you're like, okay, well, what am I gonna do, you know?
And a question for Mark. Mark, did you look at the response? Because you had at the same time frame the response and your KIM-1 response. So did you look at the biomarker compared to the response rate? Biomarker change?
Yes, we looked and we found that patients who had a complete response had lower levels of KIM-1 compared to partial response, and lower compared to ST, and lower compared to progressive disease, so all across the board.
So, Rana, question. So, a few years ago from Checkmate 214, we reported patients who had a poor risk. If they had more than 3 risk factors by MDC, 4, 5, 6, didn't do well at all. And so maybe it would be interesting to look and see if those patients who had PD had the low checkpoint, as well as whether they had 4, 5, 6 risk factors. I mean, we're still thinking, you know, we're beyond IMDC, but really in reality, they're still valid. Yeah. I think those patients don't do really well if they had 4, 5, 6 risk factors.
I mean, I think it's important to tease out, you know, we see those patients in our clinic that come in with like 5 or 6 like risk factors, you know what I mean? Like all 6, like they're like getting wheeled into the door sometimes. So I think we need to tease, when we're looking at clinical parameters versus like really trying to we need to tease out biology versus like just poor performance and inability to get through treatment, you know?